In today's video, we're going over surgery versus physical therapy for ACL tears. What's going on, guys? This is Dan and Kevin. We are physical therapists from Champion PT and Performance. We're here today breaking down the literature on surgery versus conservative care for ACL tears. We'll share with you all the good stuff that we have found. How you doing today, Kevin?
I'm doing well, Dan. I'm excited to kick off this series here. I think this will be an interesting one because I think when we think of ACL tears, we often just think of surgery, but I know some new things have been coming out that you're going to teach us about today.
Yeah, I'm pumped. Let's get right into it. All right, so let's summarize what we're going to go over today. First point, we're going to talk about can ACL tears heal? This has been kind of a interesting thing that's been poking around the internet recently with some more recent research about the cross bracing strategy, which we'll go over in a bit. The next piece is, do you even need an ACL? Because for a long time, we kind of had knowledge about copers versus non-copers. And all that means that some folks do really well without an ACL, and then some don't, right? And this actually might be related to the folks that actually heal, which is kind of interesting. Next, we're going to go over surgery outcomes versus non-surgical outcomes. This is going to make up the large majority of what we're going over today. So we'll talk about overall knee health, joint stability and function, whether or not you develop osteoarthritis with surgery versus not, and also patient activity levels. One of the big issues after ACL reconstruction or ACL injury in general is that folks don't go back to their normal activity level. And this is a problem because that leads to things like sedentary behavior, worse health, so on and so forth. So we're really concerned about returning these folks back to their sports and activities. And that is important. But another big problem is these folks aren't getting back to activity. They're getting less healthy, and that's not great, right? Next, we'll talk about return to sport rates, and we'll talk about pivoting sports versus non-pivoting sports. We'll also talk about what are the most pivoting sports, the highest level of pivoting versus moderate versus low, and how it influences return to sport rates. And lastly, should your patients undergo surgery? And I think at the end of the day, you want to make sure you have a really good surgeon that you can refer your patients to make sure they're getting the best decision and they're making the best decision. But I think the other part is that I think PTs should know about this research. We can help to guide patients as well. And the other piece is that every once in a while, you're kind of saving patients from a bad decision from a surgeon's maybe not abreast of the literature or is pushing a new strategy or something along those lines. So that's it. What do you think? Is that going to be a good one today, Kevin?
It's going to be good, man. I think the big question that I would have and that I know others would have is that, if we do avoid surgery and try to do this conservatively, is what's going to be the long-term risks of that, So I'm excited to see what you found.
Ooh, okay. All right. So when we're talking about physical therapy or conservative management, what does this mean? Because we know that you can do all different types of rehab protocols. The quality of physical therapy is going to go up or down based on the practitioner, provider, location, so on and so forth. So that's a problem, and it's hard to control in some of these studies. But at least in one of the main studies we're talking about today, conservative management is defined as progressive physical therapy. And obviously, that's going to vary from study to study, where patients are educated on how to prevent instability after they have an injury. They also use a hinged knee brace. And we'll talk about this a little bit later. But if you want to see a very in-depth rehab protocol after someone has an ACL injury and didn't have surgery, right? So a conservative rehab protocol, you can check out the article on cross bracing because they have the exact protocol that you can follow and see what they prescribed to get these same return to sport rates, outcomes, so on and so forth. So I wanted to kind of go through a lot of that, but this is already a really big lesson. And as I was going through this rehab protocol, I was like, this is an entirely different podcast episode. We can't get too crazy, but if you want to check that out, link in the show notes, right? Hey there. Sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video. First question we want to try to answer is, do ACL tears heal? In common wisdom, and this is kind of what I was taught in school, is that ACL tears generally do not heal well due to limited blood supply. Did you learn that, Kevin?
Yeah, that's exactly what I learned.
Yeah. And here's the thing. We have research about whether or not these ACL tears are healing. And essentially, they're looking at ligament continuity. So what that means is they MRI someone's knee after they've had a ligament injury, and they just look and see if the fibers are continuous, right? And that ends up being a point of contention just because when you have fibers are continuous, doesn't necessarily mean that that's a strong ligament. I think that's one of the reasons why a lot of folks are very skeptical of this newer research coming out showing that ACLs do actually heal, right? But here's the thing. If you just take individuals and put them through a rehab program after having ACL tear, only 30% of those folks will show ligament continuity at the 2-year mark via an MRI. This is based on the Canon trial. And what's funny is that we kind of knew that around 30% of folks are copers, meaning that after you have an ACL tear, complete tear, around 30% of those folks do okay. What we're finding is about 30% of those folks have an intact ACL or they have continuity, right, via MRI. So the folks that are having their ACL heal somewhat, maybe that's the reason why they're copers, right? We're not really sure if that's kind of the point, but that was interesting to me when I read it. And here's the thing. There's something called a cross bracing protocol. It's gotten really popular recently from research from Stephanie Philbay. And essentially what happens is you tear your ACL, and as opposed to getting surgery, they just brace you at 90 degrees of knee flexion. The idea is that when you flex the knee to 90 or greater, it will slack the ACL and allow the ACL points to come together, right? So if you tear the ACL in the middle, when you bend the knee, it brings them back together so they're touching, so we can allow it to heal, right? What they found is about 90% of the folks in that study, so 72 out of 80 with complete tears, showed MRI continuity at the 3-month mark, which is pretty wild. So at 3 months, nearly 100% of those folks have continuity. And here's what's also pretty interesting and very promising, I think. So more healing on MRI correlated with better self-reported knee function and knee-related quality of life, higher return to sport rates, and reduced knee laxity. And this is pretty marked. We'll talk about that in a minute. But before we move on, any thoughts about this, Kevin?
Yeah, that's interesting. So just to summarize, the 30% was showing that that's unrelated to the cross bracing trial, right? Like that's 30% of people that do physical therapy or whatever before surgery. 30% will have some continuity of the ligament.
You got it. Yep.
Okay. Yeah. I mean, so yeah, that could be, like you said, are those just the 30% copers that are getting to that point? But that is a huge difference. 60% improvement with that cross bracing technique.
Yeah, and what I thought was really interesting is this kind of goes for a lot of other tendons in our body. If you have an injury to like the extensor tendons in your finger, if you just splint the finger straight for a while, it does actually heal back. And when I was kind of under the impression that the ACL, you can't do that, but it looks like 90% or so at 3-month mark, if you do that, it is something that's potentially allowing the ACL to heal down a bit better, right? So that's pretty cool.
Yeah, and like you said, I think the thing that we care about most is what's the function like, right? Other than just how it looks on the MRI, but that also looks interesting. It seems like there is a relationship there.
All right, so talking a little bit more about this cross bracing protocol. So like I said, these individuals had a complete ACL tear, and then they were put in this brace, mobilized at 90 for 4 weeks after the injury, and then they didn't get rid of the brace right away. I think this was something that was important for me to understand. So they're braced at 90 degrees initially to shorten the ACL and allow it to heal, and then they had a slow incremental increase in extension range of motion after that. And essentially, they continued to do that until the 12-week mark when they completely got rid of the brace. But folks are able to do more and more after the 4-week mark. At 10 weeks, they were having unrestricted range of motion with physical therapy. So they were doing things like gait training and then also strength training. So they're going through that full range of motion with these patients at the 10-week mark, even though they were wearing a brace a little bit in their off hours from PT. And then 12 weeks, they completely got rid of the brace, right? So it was 90 degrees, 4 weeks, then slowly increasing the amount of extension, slowly increasing physical therapy. And at the 12-week mark, they got rid of it 100%, right? And they actually had a pretty good physical therapy rehab protocol, at least in my book, right? And I will leave a link in the show notes if you guys want to check that out. Physical therapy consisted of lower limb neuromuscular control, muscle strengthening and power, and functional training to enable return to sport and recreational activities. What I will say, and I was surprised by this, but the rehab protocol actually pretty closely resembled an ACL reconstruction protocol in terms of timelines. So around the 3 to 4 month mark, they're incorporating some plyometrics, hopping, agility. The protocol was pretty in depth, right? What I will say is they're returning to sport activities a little bit earlier than maybe your standard ACL reconstruction, but overall it was actually pretty dang close, right? And I think one of the appealing things with a non-op, rehab from ACL would be hopefully get back a little bit sooner. But I think time will kind of tell, right? In terms of like, is that actually appropriate or not, right? We're in the infancy of figuring these things out, right? Any thoughts before we move on, Kevin?
Do you happen to remember when those patients could start either like open chain strengthening or closed chain strengthening and that type of thing? Or was that kind of, I would imagine there's a period of non-weight bearing immobilization where they really can't do much, maybe for the first 4 weeks or so. But do you remember anything about that?
You'd have to go back and fact check me, but I think it was at around the 4 week mark they started physical therapy, and at that point they were able to do some strength training. But I wonder if they were kind of limited in terms of their range of motion early on, and they were allowed more over the course of time. Yeah, you'd have to go back and check that out. We probably just need to do an entire podcast on it. It's just so much. Yeah.
But kind of similar to other surgeries. So, a little bit conservative early on, but then you could start doing more in PT, but you're still braced at home and that kind of thing.
Yeah, I was surprised just by how close it kind of mimicked the regular ACL reconstruction protocol, because I thought it would be very different, and we'd have to kind of like talk about the nuances, but it's pretty dang close. So I thought that was interesting and probably good because you probably want to see similar rehab protocols, the non-op versus operative, just to kind of control things a little bit better. And I think they did a decent job of that. All right, so some more data about this cross bracing strategy. So somewhere between 5 and 18 months afterwards, it was variable, I guess, based on the individual. There was around a 14% ACL re-injury rate. And we'll talk a little bit more about re-injury rates, but they're as high as like 40 to 50% in some sports, right? So 14% isn't too bad. But then again, if you have certain populations that don't play sports, it's probably lower than that. So hopefully we'll have more data over the course of time comparing a cross bracing strategy versus just regular ACL reconstruction, bone, patellar tendon, bone as the gold standard to kind of see. Another thing I thought was interesting is that there were some DVTs, right? So one of the problems by bracing someone at 90 for a month and they're not moving at all is potential DVT. And that was interesting because as soon as I heard about that cross bracing strategy, I was like, I wonder if there's any blood clots. And well, there were 2. So that's something to be on the lookout for. Obviously, there are blood clots with other surgeries as well. So I don't know if it's more or less generally than other ACL reconstruction. That seems a little high to me, but obviously I'm not sure. So the other thing that was interesting, and we are noted towards this, but ligament continuity correlated with better ACL-OA scores. And this is an MRI injury scoring system. I had to look into this a little bit. So they're trying to grade the health of the ligament based on the findings from an MRI standpoint. And what was interesting is that if there was continuity of the ligament, that had much better outcomes. So if you had ligament continuity, had a 92% return to sport rate versus 64% without continuity. Normal knee laxity was 100% in the folks that had continuity and 40% in the folks that didn't. And then knee functioning and quality of life, those are both better with continuity. So if it did heal, people tended to do better, right? And the last thing I will say is that you may not need an intact ACL to successfully rehabilitate, right? We kind of know that from prior studies, copers versus non-copers. But what might be happening is that the copers are actually having some ACL healing, and we just didn't know that at the time. Any thoughts with that, Kevin?
Yeah. You may have said this, but do you remember is there like an age range for the patients that were used in this study, or an activity level?
Yeah, I don't want to misspeak. I want to say like 25 to 35, but then again, like I'm not even sure if that's right. I looked through so much research recently. You have to
Yeah.
go back and fact check me. What we probably
Yeah.
need to do is get her on the podcast at some point, hopefully. Yeah, it's a good study. It's very interesting.
Yeah. And I would say that, just keeping that in mind, I guess, like you said, it really depends on the sport, because certain sports, the re-tear rates are so high, especially in certain populations, like an adolescent female. But 14% re-tear or re-injury rate is really not that high in the ACL research world. So, depending on what they're doing, that is fairly good.
Yeah, and I think they had a large variety of sports too. And I
Hmm.
imagine like the level of activity is probably important, right? And then the specific sport, obviously, we know is important too. We can talk about that a little bit later as well. But yeah, just more research needs to be done. But overall, this was pretty interesting. I can see why people are very pumped about these studies coming out. All right. So, what about surgery? What the heck is surgery for the ACL? So, if you've treated patients in the past for ACL issues, you obviously will know this. But essentially, the most common surgery for a torn ACL is going to be reconstruction of the torn ACL. So, it's not a repair, although we will talk about repairs in the future. So, what they do is they try to reconstruct an ACL, and this is with a graft, right? And they can take the graft from a variety of different places. So you can take the graft from the person, right? So the person had the ACL surgery. You can take the graft from that person. This can come from the patellar tendon. It can come from the hamstring tendon. They'll often combine the hamstring tendon with the gracilis, right? I'll call that a double bundle. So essentially, they combine the hamstring with the gracilis, semitendinosus, and gracilis to make the graft. And the new kid on the block is going to be the quadriceps tendon. And what's also interesting is that you can have, let's say, a bone patellar graft. What's interesting about patellar tendon is that it attaches bone to bone, side to side, and there's essentially not a lot of space between the tibial tuberosity and patella. So they can harvest that and they can put that right inside of the knee. And you have two bony blocks. And the thought is that those bony blocks actually heal down better than if you just put the tendon into the bone, right? So you can do the same thing with the quadriceps. But what you'll also see is are completely soft tissue grafts. So you can have basically a chunk of bone from the patella followed by the quad tendon that they harvest, or they could take 100% soft tissue, which I think is more common. It's definitely what we see more of. I was talking to Lenny at Champion, who's one of my coworkers. He's a ton of ACLs, but I think the majority of surgeons, when you hear about a quad tendon graft, it's all soft tissue. It's not actually taking that bony block. Get ahead of myself, but one of the thoughts was that the bony blocks heal a bit better, but more subsequent research has shown that there's really not much difference between having the bony block and not. There is some subtle differences, but I think that has changed over the course of time with our understanding. You can also have a graft from a cadaver, and we'll talk more about this, but the cadaver graft can come from a whole bunch of different places in the body, which is interesting. And if we are going to be looking at the studies in the next few slides, which we are, I don't know which, if we, I don't know why I said if, we're definitely going to look at them. So looking through these upcoming studies, when they're comparing surgery versus conservative care, they're looking at reconstruction for the large part. They're not comparing against repairs or this bridge enhanced ACL repair, which we'll talk about as well, right? The other pieces that you may see these pop up here and there, not very common, but you can repair the ACL. And we'll talk about this in the next podcast. And another new kid on the block, and this is actually occurring mostly in Boston, which is interesting, is the bridge enhanced ACL repair, where they will repair the ACL, but they'll also put a scaffold in there to try to get the ACL to heal, which is very interesting, which seems promising so far. But we're not talking about this surgery, okay? We're talking about ACL reconstruction versus non-op folks, right? That making sense over there, Kevin? You hanging in there?
Totally. Yep. Makes tons of sense. And I think, like you had said, that's the majority of what folks are going to see. The bear seems to be gaining some traction. But in my 6 years of being a PT, I haven't seen any repairs, primary repairs, but I have seen a couple bears. But like you said, we're in Boston, and I know that's kind of where it was originated. And, we're still seeing the large majority being reconstructions, but that repair is something else that I think people are seeing a little bit more of, specifically the bear.
Yeah, and I also say I'm not sure why there's a doc at HSS that likes to repair, right? And for the right candidate, I think it'd be a decent idea. I'm not trying to say it's bad or anything like that. I think Lenny has seen one patient with a repair, but very uncommon. And we've seen a couple now with the bear. I want to say 2 or 3, something like that, but still pretty uncommon mostly. So just a little background on ACL injury types. So when you have a sprain injury, you can have a grade 1 sprain or you can have a grade 3 sprain. Obviously, it's grade 2 as well. So essentially, if you have just a grade 1 sprain of the ACL, you treat this conservatively, right? The grade 1 sprain of the ACL is defined as the ligament is stretched slightly, but the stability of the knee joint is not affected. Grade 2 is also generally treated conservatively. This will encompass partial tears as well. But a grade 2 is described as a stretch of ligament to the point that it becomes loose. This is also referred to as a partial tear, as I mentioned previously. In grade 3, this is generally treated surgically, and this is the ligament being completely torn into 2 pieces. The knee joint is no longer stable, and this is actually the most common type of ACL injury, and it's what we're talking about today. So if you have a grade 1 or a grade 2, is this a problem? Will you see these from time to time? Yeah. But these are usually not the folks where we're really concerned about, are they going to get surgery or not? So if I have a grade 3, one of my first thoughts is like, we need to go to the surgeon. We got to figure this out, right? I'm not thinking like conservative treatment right away. We're trying to figure this out. Anecdotally, I treat very few to no patients that have had a complete ACL tear, and we've made the decision to treat them conservatively. Have you treated any of these folks completely conservatively, Kevin?
No, just pre-op, but not with the hopes of avoiding surgery. But I have a feeling if you ever tore your ACL, you'll be having that thing non-operatively.
Yeah. I've accidentally treated a few folks that had a complete tear of their ACL. Some older individuals who were having some pain, were treating them, didn't think anything was going on. They go back in, get an MRI. That ACL's been gone for years, right? They had no idea. And a few athletes, too, that have retorn, and they just didn't know and kind of rehabbed a little bit on their own. Think of one individual, a champion right now, who plays at a very high level, tore his ACL a couple years back and is still playing at a professional level in sport, which is pretty cool, too. He definitely has issues that he's dealing with on a regular basis, but I'm not seeing patients wanting to go conservatively, usually after a complete ACL tear. So interesting. Who knows? The future will kind of show more, but it's not something I'm seeing.
I would say that's right. I can think of, now that you say that, a couple older folks who maybe had an allograft when they were younger, and I don't know if it's higher in allografts or anything like that, but then they will have a subsequent MRI just because they're having knee pain as they got older, and they'll find that their ACL is torn or gone or whatever. So yeah, those folks seem to be having maybe different types of knee pain unrelated to that, but they tend to be pretty surprised to learn they don't have an ACL, which is kind of interesting.
Yeah, it's like, well, what do you want to do at this point, Because they pretty much got on with life for years and they've been okay. So,
Right, exactly.
Do you want to go for it or not?
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free Certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
So we're going to be going over this study here, and it's called Conservative versus Surgical Treatment of Anterior Cruciate Ligament Rupture, a Systematic Review. So this is pretty cool because it's in 2024, and they went over a lot of different studies to try to figure out, basically, should you get surgery? Should you not? Should non-surgical management even be a thing, right? And here's one of the big takeaways from this study before we get into the details. I just took this quote directly from the study. Current literature does not conclude whether operating on patients with an ACL injury is more beneficial than not operating. In addition, there's no clear consensus on whether surgery benefits certain patient groups more than others. Clear evidence-based guidelines must be introduced to avoid unnecessary surgeries. Crazy statement. Another statement here, this literature review evaluates whether surgical management of ACL injury is superior to non-surgical treatment. You ready to dive in, Kevin?
Let's do it, man.
Let's do it. Okay, so this study was looking at 5 different papers, total of 462 patients. They were greater than 15 years old. One of the issues is that you had mentioned this previously. It's important to know the population just because some of the studies contain younger folks and some of the studies contain older folks, and that's going to give you a different outcome, right, based on the individual. They're looking at ACL tears that were complete, so no sprains in this study. And they were looking at ACL reconstruction or conservative management, which we defined what conservative management was previously. Obviously, it's going to be a lot of variation from paper to paper, individual to individual, where they're going to physical therapy, so on and so forth. They're looking at autografts and allografts, which ends up being a bit of an issue because we know there's a difference between autograft and allograft outcomes, right? So that muddies the water some. And essentially, PT group received PT education about instability, reduction, I think the hinge brace as well. In terms of outcome measures, we're looking at overall knee health, joint stability and function, development of osteoarthritis, which is important because after you have an ACL injury, regardless of what you do, usually those folks tend to have more osteoarthritis moving forward in the future. And also patient activity level. Like I said previously, this is a big problem we're starting to find out more and more. After you have an ACL tear, your activity levels go down. Health goes down. It's not a good thing, right? So if we have a surgery, is that going to be better than if we don't have surgery for long-term activity levels? All right. We also looked at return to sport timelines in this study. So differences in patient outcomes for surgical conservative management between professional athletes and regular individuals. The exclusion criteria were multi-ligament knee injuries and also having a history of previous ACL injury. And then from an outcome measure perspective, they're looking at the IKDC, the Tegner-Lysholm Knee Scoring Scale, and the KOOS, right? So we had a variety of different outcome measures, and they're looking at a whole bunch of good stuff in these studies. So Sukas et al. Was a prospective cohort study, and they had all males, no females, which is kind of a problem, 32 total patients. The average age was 32. And the follow-up period on average was 10 years. Kessler et al. So looking at 68 males and 41 females, average age of 30.7, and the follow-up period was 11 years. So it's quite a bit of time to expire. Frobel et al., randomized control trial, 32 females and 89 males. Average age was 26. The follow-up period was 5 years. Then Sandberg et al., another randomized prospective study, 200 patients. Average age was 28, and that follow-up period was 33 months. So I think that follow-up period is particularly important just because you need time to develop osteoarthritis. And I think the other thing that's important is that these folks are actually pretty young. So it takes time to develop. And I think age is a big variable with folks that have or are going to get osteoarthritis. So we probably need a lot of time to expire to see whether or not these folks are gaining osteoarthritis or not. I think some of these studies were decent, but I would love to see 20 or 30 years out. When you're a young individual, so if you're 20 years old and you have an ACL injury, it's still going to take quite a bit of time to develop osteoarthritis. And these studies were looking at that somewhat, which I think was good. But obviously, we want to follow these folks out longer to see if there is a major difference. All right. So, Kevin, do you think there were differences between the groups?
I'm going to say there were maybe some small differences.
There were a few. Let's go through a couple of them. So the Suka study and the Kesley study, they showed that surgery had a higher IKDC score. The Sandberg study showed no difference between the Tegner and the Lysholm scores. Conservative patients reported more giving way versus no giving way in the surgical group. For Frobel, these individuals were older, I believe. There's no difference in the KOOS. So for pain, symptoms, function, quality of life, or sports, might be because they're older, who knows? And then from a knee stability standpoint, in the Frobel study, the conservative group, 33% had normal Lockman and 40% had normal pivot shift. So it makes sense. They have no ACL anymore. They're probably going to have positive special tests. And the operated group, 76 had a normal Lockman test and 76% had normal pivot shift. It's kind of wild. About 25% of those folks still have positive special tests even after ACL reconstruction. But yeah, it seems largely that outcomes are similar between the groups, which is pretty interesting. And then the group that doesn't have an ACL, they seem to have a little bit more laxity. That's kind of what I found overall. Is that surprising to you, Kevin?
Yeah, I think that, one thing that pops out there is on that last one is that, like you had said, that still means about a quarter of them potentially had a subsequent injury to their ACL. Maybe without noticing or maybe with noticing, but that does kind of line up. You see anywhere from 10 to 25% of reconstructions fail or you re-tear at some point. The other thing I think is that the study is obviously trying to answer some important questions. And like you said, one of the merits of it is that it looks a little bit longer term when we might see, obviously right after surgery, those folks are probably going to be doing pretty well, like 2 and 3 years out. But what does it look like as we get a little bit longer out of that surgical timeline? But I think this study, like a lot of other studies, if it does pile together groups of different individuals, with different goals and activity levels, it does make it hard to still parse out what the best option is, right? Because I think it was over 15 years old was the criteria, right? And then there were maybe one of the exclusion criteria was a multi-ligament injury, but it didn't mention if there was a meniscus injury or anything like that, right? So it's just the more specific the studies can be, the better we can apply it to your specific patient, right? So the 17-year-old female going back to senior year in high school or going to play college sports, I think, finding those specific studies to look at that person. But I think this still, really gets the gears turning about questioning what we've always thought, that we need to do surgery because some of these outcomes, are pretty decent non-surgically. I think we just need to continue to get better studies over the course of time that make it more specific, because that's what I would envision, right? There's going to be best practices for each individual. And if you can match them to a study cohort, I think you can help that person as much as possible.
Yeah, without getting too crazy, there's so many variables influence things like re-tear. And then if they're not being controlled in future studies, when you're trying to compare conservative versus surgical, it's a little tough. It's pretty challenging. Maybe now that we have this knowledge, though, ACL is interesting to me because there's a crazy amount of research. Like when we were doing our deep dives, our literature reviews, we're like, oh my God, this is crazy how much research is coming out. And it's good. That's a good thing. And now that you have the cross bracing protocol coming out, I know that Phil Bay, that their group, they're doing lots of additional research, which is really cool, right? So hopefully this, research will continue at the same rate, and we'll get more of these questions answered because it's important, right?
Yeah, that I actually tell that to a lot of my ACL patients is like, I'm so sorry this happened. It's such a bummer. But one of the bright lights of it is that there's so much research for this condition that, it allows us to know what to do better to help you. It's not one of those very obscure things that is never really studied. It's one of the probably most studied, I would say the most studied sports injury that I've come across. And it has to be one of the most studied musculoskeletal injuries. So, there is a lot of information out there, and parsing through it all is definitely challenging.
Yeah, it's not like Pez answering pain where there's one study on physical therapy, and physical therapy consists of ultrasound with no control group,
Yeah.
All right. So from the Tegner activity scale standpoint, the Tegner activity scale, if you listen to our meniscus podcast, is essentially what level of work or sports activity you engage in. So a really high Tegner activity scale would be you're getting back to professional sports. And then a really low would be like you're sedentary with a lot of disability going into the surgery, right? So Sukas in 2016 found a slight drop in the conservative group. So essentially, conservative group was not able to return back to the same level of activity. Kessler in 2008 found no difference. Frobel found a significant benefit in the surgical group at 2 years, but no difference at 5 years. Then Sandberg found a significantly greater return to sport timeline for the surgical group. So a little bit mixed, a little bit all over the place. So kind of interesting. And then laxity testing. So this is important. We learned about KT 1000 testing back in school. I find that not a lot of folks know this coming out of school anymore. Did you learn about this, Kevin?
I did. Yeah, I remember learning about this.
Yeah, so just use a machine to assess the amount of laxity within the knee joint, right? To see anterior translation and see if there's a difference, in norms or on the contralateral side. And there was significant increase in laxity in the conservative groups overall. And I think a big takeaway with a lot of this research is that the conservative group tends to perform similarly to the surgical group in a lot of areas, but not laxity. Seems like these folks still present with significant objective and subjective laxity. So they feel the laxity, and then it's also being picked up when they measure it. From a physical activity standpoint, Sukas, Sandberg, and Kessler all found that non-operative patients' satisfaction with their ability to participate in physical activities decreased more with time than the operated group. Next, osteoarthritis. This one's particularly interesting to me just because one of the main reasons I would consider surgery versus not would be the long-term health of my knee. Am I going to have more osteoarthritis if I don't get an ACL reconstruction? I mean, logically, it makes sense. If you don't have an ACL, you're not going to be able to control motion within the knee joint as much, causing meniscus pathology, causing more osteoarthritis, right? Is this what the research is showing? So Nebulung et al. Showed increased risk of high-level athletes with definitive unstable knee developing cartilage lesions over 20 years. And then Sherman et al. And Naret et al. Reported that chronic knee instability leads to cartilage degeneration. Newman et al. Found osteoarthritis in 51% of men and 41% of women with ACL injury after 12 to 14 years. So as I said previously, we know that when you have an ACL injury, and this is going to be with ACL reconstruction as well as non-op, right? You're going to have an increased risk of osteoarthritis. We know that. And that's unfortunately a side effect of having an ACL injury that we would love to be able to correct, right? But here's what's interesting. Despite the evidence supporting the importance of an intact ACL in decreasing the risk of cartilage degeneration, the literature does not prove that reconstruction reduces the risk. So essentially, you tear your ACL, probably going to have more osteoarthritis, but getting the reconstruction doesn't seem to change that. Sukas in 2016 showed no significant difference in osteoarthritis between the groups, and this was going to be radiological arthritis as well as symptomatic arthritis via the KOOS. Kessler in 2008 showed significantly more osteoarthritis in the surgical group, which is very interesting. You'll find some studies where the ACL reconstruction creates more osteoarthritis than the non-op group. And Frobel in 2013 showed no difference between the groups, and there was an insignificant trend towards more osteoarthritis in the surgical group. So this is super interesting, Kevin. What are your thoughts on some of this data?
Yeah, I was actually talking to our PT student at Champion yesterday, Gavin, about this.
Go, Gavin.
Shout out to Gavin. He's doing great. I love Gavin, but he had ACL reconstruction himself, so he's really interested in this stuff and trying to figure out that long-term risk of arthritis. And I think some of the things you said there just make me wonder if there are different mechanisms for arthritis in those two different groups, right? Because the group that has more instability, those folks maybe being managed conservatively with that instability over time might lead to more arthritis. But then surgically, I think depending on the type of graft, I wonder if, just totally wondering here, if allografts have a little bit less arthritis because you're not drilling into the bone as much and harvesting other tissue, and the portal holes that occur with the grafts during a reconstruction, that that's going to create a lot of trauma in the knee, and then you have that period of months of swelling and pain, and is that cascade that's causing arthritis a little different than the instability over time? So it is interesting, and you wonder if with a good rehab program, conservatively, you can reduce some of that instability, but it does seem like you're going to have it in, I guess, which one's going to lead to more arthritis over time is the question. So either way, it doesn't seem phenomenal for the long-term health of your knee.
Yeah, and we'll talk about that a little bit too, because that is one of the potential benefits of the repair or the Bayer procedure too. And we do have some preliminary research in animals showing there's less osteoarthritis than a reconstruction. So that is pretty interesting. The other thing that goes through my mind, and this is kind of coming from the OptiKnee paper from Whitaker, I know she talks about this, but you're more prone to sedentary behavior after you have an ACL tear, and that's going to be surgical and non-surgical, and that's a problem. And we know that having higher body weight is a big problem for knee osteoarthritis. It's one of those big risk factors. So maybe it has something to do with their lifestyle, what happens after the injury, and not necessarily that they're not able to control motion within the joint. It might be that accumulation of body fat, the pro-inflammatory nature of body fat, creating more arthritis over the course of time. Who knows? Just a thought, right? Obviously, the injury by itself creates trauma in the joint. Surgery also creates trauma as well. So maybe it has something to do with that. Hopefully time will tell. We can figure these things out a little bit better, get some better long-term outcomes for our patients. All right. So just a couple of concluding remarks. Frobel concluded that there's no difference generally between surgery and non-surgery. And this goes for symptoms, knee-related quality of life, general physical or mental health status, daily activity function sports, return to pre-injury activity level, radiographic osteoarthritis. In this study, and this is important, athletes were excluded, right? So largely, if you're a non-athlete, then maybe there's no difference. But the other really important thing that I found in this study, which I thought was funny, 51% of non-op group patients went over to get a future surgery. It's kind of like, all right, well, is this really a great option if more than half of folks are getting additional surgeries? And I don't think it was all folks going on to get ACL reconstruction in the future. It was other surgeries as well. So things like meniscectomy, repair, potentially that type of thing. But yeah, I just thought that was an interesting thing to note. Fink in 2001 said conservative patients that return to sport had increased osteoarthritis and may benefit from earlier ACL reconstruction. So there is still that thought that if you want to get back to sport, and we'll talk about this a little bit later, ACL reconstruction may be the way to go. And that's kind of the way it goes now. From my experience, if you want to get back to a pivoting sport, docs are going to say, yeah, get the reconstruction. That's kind of the way to go, generally speaking. Okay. A couple important limitations of this study, just because right now there's a lot of hope, I'd say, in terms of conservative management of patients that have a complete ACL tear. And I think that's warranted, but there are some major limitations of this study. So when you see these really nice outcomes in terms of very similar return to sport rates and satisfaction and outcome measures. You have to keep in mind that these studies aren't perfect. So there are different lengths of follow-up in each study. Like I said, there's like between 2.5 years and 11 years. Maybe that changes over the course of time. There are different ways of measuring these outcomes used in each study. Despite that, some common ways between some studies were used, right? So different outcome measures in general. Can't always say that one outcome, saying the outcome measures are good in one study and they're using a completely different outcome measure in another study. They might be dissimilar from that reason. Different surgical techniques and different surgical teams with experience levels not specified were used in these studies. Like I said, there's autografts, there's allografts. We know that those have different outcomes. They weren't controlled for. Rehab protocols were not specified. That's a problem because rehabs can be very different across the board. Only 5 papers were eligible, and I thought this was crazy, right? And they included only one randomized controlled trial, which we need more of those. I think one of the reasons why they didn't have more trials was because the search results were restricted to only open access articles, which when I heard that, I was like, how relevant is this entire article, right? And that's a big problem, I think, for researchers right now, is that we have to have more access to papers. This is stupid, right? There's a giant paywall out there that's keeping us from being able to figure out things that we need to figure out, which is kind of crazy, right? And the muscle strength and pre-injury activity level of patients in some studies were not specified and were not accounted for. This can affect outcomes and recovery. And all papers had a mean age between 25 and 35 years old, but Sandberg et al. Included patients up to 61 years old, which possibly affects the comparability of the results. If you have a bunch of 61-year-olds, do they need their ACL? Maybe not as much as the 20-year-old, right? But you're comparing these results across all these studies, and it's like comparing apples to oranges in some ways. Any thoughts quickly before we move on there, Kevin?
Yeah, I think those are important to keep in mind because, I remember when the cross bracing paper kind of came out, you see on social media, people either love it or hate it without really considering all the nuances of the paper and the limitations and those types of things. So I think it requires a deeper dive to try to get these answers rather than just looking at the abstract, right? And figuring out, always asking how this information applies to the person in front of you and trying to see if the studies that you're looking at match that, the patient that you're working with. So, overall, I think it's interesting information and things that we need to consider and be on the lookout for as more and more research emerges. But keeping the pros of the paper and some of the limitations of the paper in mind are always important.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up. It's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
All right, let's go over return to sport. So these numbers are coming from Keys et al. In 2022. A little history before we talk about that. Return to sport rates after ACL reconstruction are generally poor, so less than 50% in some studies. That's some studies, right? That's a pretty bad number, but generally they can be quite poor. ACL reconstruction versus non-operative management are generally similar, which is kind of crazy at the 1-year mark. So this study had 101 papers with ACL deficiency. They had 56 patients in the ACL reconstruction group, and they followed up 9 years after the surgery. They had 45 patients in the non-op group, following up at 11 years afterwards. And their question they want to answer was, are long-term follow-up results same as short-term follow-up results? So basically at the 1 year mark, or looking at the short-term outcomes, does that stay the same after 10 years, right? Because maybe if you have ACL reconstruction at the 10-year mark, that outperforms, let's say, conservative care, but at the 1 year mark, it looks exactly the same. I'm going to give you a bunch of numbers here. And the first number is going to be the reconstruction group. And the second number is going to be the non-reconstructed group. And these are all return to sport rates. So reconstruction group, 96% versus 93%. And the non-reconstruction group continue to play sports. So they get the 10 years, and then the large majority are still playing sports. So 4% versus 7% did not return to sport. 8% versus 17% return to safer sports. So safer sports generally means things like weightlifting and running, right? 13 and 12% return to running. 20% versus 26% return to sports involving twisting. 12% versus 24% return to recreational pivoting sports. 43% versus 14% return to competitive pivoting sports. And I tell you what, that's a pretty big discrepancy there. And the authors found the only significant difference was return to competitive pivoting sports. And the folks that had the reconstruction had 3 times the rate of returning to these competitive pivoting sports compared to the non-surgical management group. After hearing those stats, Kevin, any thoughts pop up out in your head there?
Yeah, I think that just is kind of in line with what we've been saying a little bit throughout, is that the specific cohort matters. And perhaps it's that group that's playing more competitive sports that might be a better candidate for a reconstruction. And those are the people that I think doctors are probably telling that they should have a reconstruction instead of managing it conservatively. So yeah, I think that's not surprising. And that's probably why you see such a big difference there, is the reconstruction for the group of people playing sports like that, competitive sports, is still the gold standard.
All right. So my next question, and I think this is actually really relevant for physical therapists, is that what is a pivoting sport, right? Because there's a lot of sports out there, and some sports probably pivot more than others. And if you start to break down these return to sport rates based on the amount of pivoting, does that change things a little bit? And I was able to find a little bit of research to help out from that standpoint to see what the return to sport rates are for different types of pivoting sports. And what was kind of cool is they broke down pivoting into different levels. So level 1 had the most amount of pivoting. This would be sports like soccer, handball, floorball, and basketball. I don't know what floorball is, and I have an idea of what handball might be, but soccer and basketball at least make sense to me, right? Level 2 pivoting sports were racket sports, so things like tennis, alpine skiing, snowboarding, gymnastics, and aerobics. And what I thought was very interesting is that racket sports and skiing were level 2 pivoting sports compared to soccer, which is a level 1, which we'll talk about the relevance in a second. But they're basically saying that racket sports are less pivoting than something like soccer. Level 3, these are supposed to be non-pivoting. And at least the study we're going to talk about in a second, they didn't study these folks. This would be running and lifting, right? A study by Grindam in 2014 showed non-op return to sport level 2 and 3 was greater than the operative group. So this is interesting. If you take patients and you don't do ACL reconstruction, right, their return to sport rates are actually greater for level 2 and level 3 sports. And that includes racket sports, skiing, snowboarding, gymnastics, aerobics, running, and weightlifting, which kind of blew my mind because the main reason why we see, I don't know, one of the major populations we see ACL reconstruction is skiing, right? So the first thing that popped into my mind was, wow, these folks actually do pretty well non-operatively. And alpine skiing is a different sport, which I honestly don't know all the nuances about, but I was surprised to hear that the return to sport rates were similar, if not even better, in the conservative group. And Overall, there was no difference in return to sport rates in ACL reconstruction versus the non-op group. However, in the non-op group, the return to sport rate for level 1 sports was 55%, and the level 2 sports, it was 89%, right? The interesting part about this is that the level 1 sports, prior to deciding whether or not they're going to get surgery, they were told not to return to sport if they wanted to get back to a level 1 activity. So one of the problems with a lot of these studies is they actively dissuade patients from returning back to sport if they want to get back to a pivoting sport, and or if a patient wants to get back to pivoting sports, they're telling them to get an ACL reconstruction. So that's a little bit of a problem from a study design standpoint, because you're naturally excluding patients from certain things from what the surgeon ends up telling them from the get-go, right? But I thought this was very interesting in that these level 1 pivoting sports don't do as well, but the level 2, level 3 do pretty decent. And this is a total anecdote, and I was talking to my wife about this the other day, but she worked at Breckenridge as a physician for a little bit, and they just see like ACL injury after ACL injury after ACL injury all day long from folks tearing their ACLs. And what's interesting is you see a lot of folks that don't get their ACL reconstructed, and they get back to higher level skiing, right? And there's quite a bit of them, just because the injury prevalence is so high in skiing, and some folks just get on quite well. But what's also funny is that I think we even have some on our schedule right now. Like, we see a ton of patients that have ACL reconstruction because they want to get back to skiing, right? But this research is kind of showing the opposite. And I'm not saying this is the best study in the world, but it's showing that folks are able to get back to skiing at a pretty decent rate. So I thought that was pretty interesting. What are your thoughts there, Kevin?
Yeah, I guess the question that pops into my head is that the study was looking at 1 year out, right? So you wonder if the people who underwent reconstruction maybe weren't hitting their return to sport tests yet at 1 year. So they were delayed in returning versus the non-operative group. It makes me wonder if they're being as closely monitored in clearing return to sport testing before going back to something like a pivoting sport, like a level 1 pivoting sport. So those are just questions that pop in my head about that. But I think the other thing is that just looking at ACL studies in general, I think it is important that the papers are kind of grouping people by these return to sport categories in type of pivoting sport, because, like I said, they didn't include running in this or weightlifting, but, those folks are going to be able to get back way sooner generally than a year, you would think, right? So when you do see these ACL papers, I think that's something good to look for, because a lot of times they do break them up by those types of groups, like a level 1 pivoting sport versus a level 2 versus a level 3. So, that's something important to look out for, because you don't want to just go by the recommendation of the average return to sport rate is 9 to 12 plus months. When you do have a weightlifter or a runner, I mean, that's going to be a lot sooner, which is good.
All right. Next question. Does a complete ACL tear increase your risk of meniscus injuries? So, Kevin, did you learn that if you have an ACL tear, complete tear, and you don't get surgery, you're going to have more meniscus pathology over the course of time?
It's a great question. I'm not sure if I learned that, but it's something that I definitely think about. And vice versa. I wonder if you have a meniscus injury that's non-op, if you have a higher rate of ACL injury. But what did you find here?
Yeah, it's just one was interesting to me, right? And like, if you look at the definition of osteoarthritis in the knee, depends on how you're grading it, but just that having a chronic or degenerative meniscus tear does classify as osteoarthritis. You know what I mean? So some of these studies were showing no difference in osteoarthritis. So thought is like, are these folks actually getting more meniscus tears? At least that's something that was going in my head. And, there is prior research showing that if you have a complete ACL tear, that increase your risk of meniscus injury. I've definitely read through some of that research, right? But this was interesting because this is more recent research. It's a study from 2023, and they're just looking at delayed ACL reconstruction versus immediate ACL reconstruction. I want to say it was at the 2-year mark. The folks had the delayed ACL reconstruction, right? And what they found is that there's no difference in meniscus pathology over a 2-year follow-up period, right? So essentially, the folks that got the ACL reconstruction versus the group that didn't, 2 years later, there's no difference in meniscus pathology, right? So their conclusion was that the ACL reconstruction can be delayed without increased risk of meniscus pathology, right? Which I thought was pretty interesting because it kind of goes against what I had learned, right? I want to say I was listening to, again, Stephanie Philbay as well as Whitaker talk about some of this data. And they were asked this same question: does a complete ACL tear risk increase your risk of meniscus injury? And they said, at least one of the individual authors said this. I don't remember who it was. I think it was Whitaker. Said it doesn't increase your risk of meniscus injury. And I thought that was interesting. So the first thing I did was I went back and tried to read the study and see, right? And yeah, that's what they show. But here's the thing that was a limitation, big limitation in my mind. So do patients return to their prior activity level after having the injury, right? And one of the big limitations that activity levels following injury were not reported in this study or prior studies showing increased meniscus injury risk. And lower activity levels may reduce injury risk. So if I have a complete tear in my ACL and I go out there and I play soccer, right, I might have an increased risk of meniscal injuries potentially. But if I tear my ACL and I don't do jack because my surgeon tells me not to engage in level 1 pivoting, which happens all the time, right? Don't do a whole bunch of athletic activities until we get this reconstructed. I think this is a little misleading as a study. And at the end of the day, we have to kind of control for activity levels after the injury because it makes no sense at all to me. You can conclude that going back to all of your activities is 100% safe when they don't even report that, right? And two things, right? As long as you're not going crazy with your activity levels after you have an ACL injury, it's probably decent advice to tell folks that it's okay to delay this, right? But if you go back to something like soccer, maybe that changes your risk. It's just that we don't know that yet. Do you have any thoughts on this, Kevin? I thought this was pretty interesting. It was kind of went against what I had learned previously.
Yeah, I think what you concluded there is kind of a theme of a lot of these studies is that they're trying to answer complicated questions, and thinking about the results after you read them is important, like you did, right? So it's important to think a little bit deeper and think about what are the limitations of the study, because yeah, if you're reducing activity level, we would expect reduced pathology after that. So that's something to consider is you can't just look at the abstract and say, oh, it doesn't matter if you get that repaired or not, or whatever. You might not increase your risk of arthritis, but you have to think a little bit. What are the next? Think a little bit level deeper, and what could be contributing to that. Perhaps it's that they're reducing activity, which we don't want to advocate for. And that doesn't necessarily make it a bad study, but it's a piece of the puzzle that can fit into your decision making.
Mm-hmm. Yeah. I don't think you can give someone the blanket advice that it's 100% fine afterwards. But like I said previously, meniscus pathology kind of qualifies as osteoarthritis.
Mm-hmm.
So they're showing very similar outcomes in longer term osteoarthritis. So at 10 years, 11 years. So at least in my mind, that's a really good sign. Yeah. So it's not like you don't get this reconstructed and you're destined for more meniscus pathology and osteoarthritis. That doesn't seem to be the case. But you're probably having people kind of self-select in terms of what activities are okay because they have the ACL injury, right? And if you're feeling some instability within that knee, probably not going to go skiing. You know what I mean? Mm-hmm. So my thought too is that if you don't get your ACL reconstructed, I think about this all the time. Like if I had a prior injury, I'm going to take it a little bit easier in activities in the future that might be a little bit riskier to that area, right? Mm-hmm. So that might be going on. People might be self-selecting. And obviously that's something that's a little bit harder to control, right? Unless you force people to return back to soccer after they have like conservative management just to see how it goes, which probably wouldn't be ethical.
Yeah. And I would say anecdotally, I definitely have some slightly older patients. So that cohort that's out of college that maybe tore their ACL playing flag football. And they tell me, like, after this recovery, I'm never playing flag football again.
Yeah.
And so they're reducing their activity level with that type of activity. And that's very common, I would say. I see people that say that to me.
Yeah. Or if they're like a hardcore skier, like I need to get back to skiing, but they're going to take it easier. You know what I mean? They're just not going to go nutso when they get back to that given activity. It's a very common thing you'll see. And lastly, it kind of brings us to the final point. Should your patient have ACL surgery or not? And I'm taking some information from a 2024 paper called ACL Tear, individualized indications for non-operative management. And essentially, they stated currently both operative and non-operative management are acceptable methods for treating ACL injuries. Factors favoring surgery are return to pivoting sports and also the very high level of pivoting. So like your basketball, your soccer, and non-copers that can't return to sport or activities should probably end up getting surgery. So if you just find you can't return back to your activities and you've delayed surgery, probably good indication to get that. Patients with subjective and objective laxity. So this would be with patients saying they're having instability within the knee, which is really freaky. And the patients I've had without an ACL, right, they'll tell you, like, it feels like my knee's like sliding around in there, doesn't feel good, right? So those patients are the ones that have objective laxity via KT1000, maybe better candidates for surgery. Folks with concomitant injury. So if you have a reparable meniscus, probably want to go in there, reconstruct the ACL along with the meniscus. Age may or may not be a factor in surgery. So advanced age used to be an indication for non-op management. That's no longer the case. I certainly have some family friends in their 70s, late 70s, early 80s now that love to ski, and they tore their ACL and they got ACL reconstruction at like 78 years old, right? And they're back out there skiing again. So I would say that age might be a factor just because it's going to dictate your activity level, but it might not. So if you're still a very active 7-year-old, you might want to think about getting your ACL reconstructed, just like the 25-year-olds. Any final thoughts here, Kevin?
No, I think that was a good summary there. I think those criteria are something you should keep in mind. And I'm sure things your surgeon are thinking about as well.
All right, guys. So now you kind of figured out whether or not your patient wants to undergo surgery or conservative management. Now you need some good exercises to get them going. We'll have a video for you. I'll leave that link right above Kevin's head. We'll go over my favorite beginner exercises for folks that have knee pain, for folks that have had ACL reconstruction, or they haven't had an ACL reconstruction and need to get going with exercises. So go ahead and click on that link, and I will see you in that video. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.